Hey everyone, welcome back to the Medical Fitness Podcast. I'm Jeff Young, CEO and co-founder of the Medicine Rehab Fitness Institute, and I'm here with my friend and colleague, Dr. Thomas Hammett, who is also co-founder of the MRF Institute and the director of operations at Pinnacle Lifestyle Medicine in Seattle. Hey Thomas,
Hey Jeff, how you doing?
I'm doing well today. So our topic today focuses on one of my favorite things to talk about and your area of expertise, which is why you're our subject matter expert in today's episode, building that bridge between rehab and fitness. I've known you for 6 years, and you and I have had hundreds of conversations on this topic. It always get just as pumped up every time. So with that said, let's dive into the first question. From your perspective as a physical therapist and medical director, where does the rehab to fitness handoff most commonly break down? And what are the downstream consequences for patients and organizations? But before you answer that, let me explain in a little bit more detail what I mean by the rehab to fitness handoff. What that means to me, as I was writing the question for you, is when patients finish their rehab with a physical therapist, commonly what happens is a discharge to a home program for whatever they were in rehab for. So that's a very common. The handoff isn't really to a fitness professional, and a competent fitness professional. Instead, the handoff is really just here's your homework that I want you to do to continue on after your rehab. So that's really what I mean when I say the rehab to fit handoff, because now what we're going to be talking about is in place of that, let's talk about the handoff to a competent fitness professional. So that's what I meant. I want our guests to know that. But if there's anything that you want to add to that to answer the question, you can. And otherwise, that's what I'm interested in knowing.
Yeah, great. That's great, Jeff. And I appreciate you pointing out that the status quo is that there is no rehab to fitness bridge, right? So status quo is discharged to a home exercise program. Patient presents to physical or occupational therapy with some condition. Everybody talks about total knee or ACL repair, right? And those are the common post-op conditions we see. We see a ton of people for pain and physical disability. And a standard plan of care lasts anywhere from 6 to 20 visits. On average, it's right around 9 or 10 visits is the average number that we see patients for in clinic. There may be some homework during the experience, physical therapy, and then afterwards there's a discharge plan of some kind. And the discharge plan status quo, to your point, is those exercises we did in therapy, just keep on doing them. Uh, and I should say that there are, and it's not a new thing, really, probably for the last 20 years or so, physical therapy groups have recognized the potential benefit to their business and to the lives of their patients in doing a discharge program of some kind, where they continue to work with those physical therapy patients beyond that short-term plan of care, the short-term rehab for their condition. So, the first answer is the non-existence of a handoff is where most of the time things break down. But when those programs do exist, the biggest issue that I see is that there's breakdowns pretty much at every level of the process to get people to engage in a program that happens after therapy. The biggest issue I see is a misunderstanding of value that long-term exercise contributes to a patient's physical health beyond what they would get in therapy, but also contributes to their rehabilitation process, right? That whole body strengthening cardiovascular exercise is really beneficial to that acute injury in one specific area of your body. We don't think of rehab for a knee, including upper body strengthening and core exercise and cardiovascular exercise necessarily, but the body's ability to heal when it is in a better state of fitness and in a better state of health is much better. So we often view that bigger like post PT exercise plan as this like other thing that you can do that we can sell you that's not related to your PT. And that couldn't be further from the truth. The value of engaging in exercise is to facilitate your long-term healing, to work on those long-term goals that we didn't get a chance to address in our short-term plan of care. Because God knows people present to therapy with more goals than just, I want to reach my arm over my head again, or I want to be able to squat low again. They want to do that and do a bunch of other things that maybe they haven't done for the last 5 or 10 years, if they're being really honest with themselves. And it takes longer than an average of 9 visits to get people to that place. And when presented that way, most patients are willing to say, yeah, you're probably right. And I probably should do something that goes beyond a short-term thing. What do you have for me that could do that? To get a patient to that place is so rare. And that's what I mean about, like, if the therapist understands the value of what long-term exercise can do for an individual in acute pain to support their physical health, um, and the value of engaging them in that behavior for longer than just what insurance covers for therapy, most of the right things can happen afterwards. But that missing understanding of value is where most of the breakdown happens. Things can happen by accident down the road in terms of facilitating the connection between, the patient and the fitness professional within the clinic. That can happen without a good understanding of value, but it's often an accident and it doesn't happen well. If you have a really good understanding of that value and that lens, it can really help. And I think there's one thing that I would say to physical therapists, and I shouldn't just say physical therapists, because this is true in cardiac and pulmonary rehab, it's true in occupational and speech, not so much speech therapy, but any rehabilitation space, there's an assumption of both disinterest on the side of the patient, that the practitioner views the situation as the patient's not going to want this, or even worse, that we're going to come off as salesy and ruin the relationship. And I wanted to give you some data because I've been really interested in this question too. And for the last 6 weeks, we've been surveying all of our new patients at Valley Medical Center. So something that if you've listened to this podcast before, if you haven't, then I'll tell you again. But I support and manage a hospital contract for a local hospital here just south of Seattle. We operate 4 separate locations of physical and occupational therapy, a cardiac and pulmonary rehab department, nutrition and medical fitness services. And for all of our physical therapy patients at 3 of these locations for the last 6 weeks, we've been asking them 2 questions. We show them a little video to just explain what PT is going to be like. And we ask, are you interested in learning about how your overall health and lifestyle contribute to your condition? Second question we ask then is, are you interested in learning about how nutrition and long-term exercise can optimize your recovery and reduce your risk for future pain and injury? Jeff, I want you to guess what % of patients say, yes, I do want to know about those things.
I think it's a high percentage. I think it's, I don't know, 70%, 80%.
Yeah, you're exactly right. It's 80%. 80% state that they're interested in both of those things. So that assumption of disinterest by our practitioners, and the sample size for that is 450 patients, by the way. So of those 450 patients over the last 6 weeks, 80% saying they're interested in both of those things. The assumption, I feel pretty confident already that we've dismantled that people do come in interested. They just need to be presented with it the right way, and it needs to feel relevant to their condition. I've got a few more things, but maybe I'll pause here and just see if you have any reflection or thoughts before I go on.
Absolutely. There's all kinds of thoughts going through my head. One is, you know, and to the listeners, I didn't know Thomas was going to ask me that question. And on one hand, I feel a little lucky that I answered right with 80%. But part of what I was thinking when he asked me the question was my first job out of college 30 years ago at Duke Medical Center, and it was it was medical weight loss. But one of the things I learned there right away is that people want to know those things. They, like in that case, I'm not just here to get to a certain goal weight. They wanted to know more about their health and the whys behind things, and they wanted to be educated, which then really spurred me on as to who I am as a professional now, is just being so passionate about education. So that's definitely one of the things that went through my head. And the other thing that went through my head, and I didn't tell you about this, Thomas, so you don't know I'm getting ready to hit you with this, is that on the MFA's exchange forum for their members, Andy Graham, the director of sales for the MFA, posted something a couple days ago, and it's titled, I'm actually looking at it right now, it's titled Study on Non-Compliance with Physical Therapy Homework.
Mm.
And so basically Ohio State did a survey, and I think it was over 1,000 patients that they surveyed over the course of X amount of months. And it says the study finds that 76% of patients skip prescribed at-home physical therapy exercises. And so Andy asked two questions for the group. One is, why is this percentage so high? And number two was, what, if anything, can the medical fitness community do to drive better outcomes? So without going into too much more detail, I want to rattle off some of these things that they found from the study, um, and the responses to the survey. One of the reasons why there was this lack of adherence to home exercise was, I forgot, or there was no reminders. That was 40% of the respondents. Not enough time or scheduling conflicts, boring or repetitive, didn't see results quickly, pain or fear of making it worse, no accountability between visits, and several others. And I'm not going to go into right now what my responses were, but I did respond to the second question, and the gist of my response was, um, that a lot of times I think you want to do what I call, in my previous experience, treat and train programs, where you're treating the issue, and you're training the person either at the same time, or like you're alluding to, you're at least talking to them about the importance of the health and training, etc. So I'm going to stop there, but that's my answer to your questions of what was going on in my head when you were saying those things. And I'd be curious, now that I just blindsided you with the Ohio State survey, what are your thoughts either on that, or can you merge that into anything further you were going to say on this topic?
Yeah, I appreciate you bringing that up, Jeff. Was that a new survey by
Yeah.
Ohio State? It's
Yes.
eerily similar. I used to use this doctoral dissertation. There's not a lot of high quality evidence published on this, home exercise compliance and physical therapy. But I found this really great doctoral thesis maybe 5 or 6 years ago. And the numbers are really similar to what you said. And the explanations are really similar too. And of course, that's the explanation. I think you could summarize it all by patients don't understand the value of spending their time doing that stuff.
That's right.
And if the perceived role of the physical therapist is to fix the condition in clinic, that stuff at home feels like unnecessary, maybe like optional. Um, Despite the fact that when surveyed, physical therapists say consistently doing home exercise is really important to success in the care plan, that people who do their home exercises consistently get better more quickly, and more consistently. So, it's funny to hear that. We know it's a problem. I think there's a lot of different ideas about in the physical therapy world about what should be done. There's, new codes that are available to physical therapists for remote therapeutic monitoring that provides, essentially through technology cues to people to do their home exercises, and gives them videos to show them how to do the home exercise kind of stuff. Again, our mindset is most people need a lot of support, and they need a lot of support for a lot longer than the acute therapy plan often provides them. Can we just give people a really solid foundation to understand what movement and fitness and health is going to do for their physical condition, and start to address that long term? And something I meant to mention earlier is, like, physical therapists live and die on this belief and role of being the movement system expert. I'm a PT, by the way, so I can say this stuff, right? So we live and die on the belief of being the movement system expert. And what unfortunately happens with that is we take responsibility for the movement system only, and forget that there are other factors that impact the movement system, other systems of the body, that's like cardiovascular system, and so on and so forth, that really affect the musculoskeletal system. And we frequently, consistently do not assess and do not support people in those areas that impact people's physical bodies that move. So if we're not supporting people with health in their lifestyles and the things that can help them build stronger bodies, we're not really living up to that movement system expert domain. And again, that comes back to the misunderstanding of value of our role and how someone in a fitness role can help us down the road. If we don't do this stuff, like really accepting that short term, like 2 times a week for 6 weeks is what, in the PT world is the care plan that you're going to hear the most. If we accept that as the inevitable course of care that we're going to provide people, we're accepting for a lot of people that it's going to be a quality issue long term. That Early discharge before people are really ready leads to recurring pain and future injury. And not doing something about integrating exercise and nutrition and other lifestyle factors throughout physical therapy care plan really leads to a missing opportunity for addressing the root cause. Just the same data set that I told you about that is giving me information about people's interest in learning about their overall health and nutrition and exercise is telling us that 70% of patients present with at least one chronic condition and health risk factor. And if we ignore that stuff, if we ignore that other part of their health, we're letting people leave our doors prone to injury and pain and future disability that's going to bring them back. And of course, there are people that aren't ready to do anything about that, and that's okay. But for the people that are ready, that want to know, for the 80% that are saying, yes, I'd like to learn about this stuff, we should be doing better for them. And that means engaging with an exercise professional during and after the PT plan of care to get people moving in a different way to support their health.
So, first of all, that is awesome. And it actually reminds me of something else that I was thinking about when you were originally talking about this. It reminds me of a little bit my dissertation research. And you're on my dissertation committee, so you know all about my research. And it also reminds me of part of what prompted my research is my frustration that and I'm not just saying clinicians, also fitness professionals and just people in general, we tend to place people under the umbrella of like one size fits all from a behavior change standpoint. And so that's kind of what my thoughts were, is that this fits into that. We're making assumptions about behavior change rather than assume. I'm sorry, rather than assess. So we're assuming rather than assessing. And then your survey is showing that if you just assessed, and there's all kinds of different ways to go about it, and with one, you're asking them two questions and showing them video, etc. But prompting the conversation, which then leads to the other part of my dissertation research, which is readiness to change. And that if we would just assess it rather than assume, then we could potentially quickly move people through. Maybe they came in pre-contemplative, but just by prompting them with the questions that you prompt them with in the video, and including some education, and then the motivational interviewing skill set, and just the soft skills skill set of you and your colleagues, just that alone could potentially quickly move them right into contemplative. Yeah, okay, I'll think about that. And then boom, by the time rehab is over with and it's time to get discharged, oh, now they're all of a sudden they're ready to be handed off. The baton is handed off to a fitness professional. So those are the things that are going on in my mind. We need to stop with the one size fits all behavior change because it's hurting our patients. And number two is, let's understand that trans theoretical model better, and understand the role that we can play, and that we might be able to move people quickly from pre-contemplative or contemplative to ready to go. And at that point, this becomes the hard and soft skill set of the coach themselves to take it from there.
Yeah, I want to respond to that just a little bit because you're so right. And, we've done a lot of work with our therapists. So there's about 40 therapists that we employ in this health system. We do a lot of work on talking about this referral pathway from the start of physical therapy into ultimately a long-term exercise plan for people that leads them to be successful with exercise. And early on, and maybe what I'll say before I get into that is one of the options that we refer to is a really short-term, kind of like an easy biteable option called Bridge, meant to be
Yes.
like the introduction to exercise. We have a long-term exercise program, lifestyle change program called Lifestyle 365. When I'm talking to therapists about this, the goal is just how do we get them into the easy step one, right? And when we were doing this early on with therapists, what I found was that the therapist would evaluate someone, and based on their evaluation would decide that someone was either appropriate or not appropriate for a referral. And that language kept getting used over and over again. And I kept thinking to myself, that's really not very good change related language. Like, we're not thinking
Yes.
about people as able to change their mind or
Yes.
dynamic in the way that they can think about this. So I suggested to our therapist, we need to stop using appropriate versus not appropriate for the vast majority of these people. Sure, there's a few people that can't physically perform the kind of exercise that we're talking about within our facilities. They may not be appropriate for what we offer. Fair. There may be people that are way too fit and need a performance lens, and we don't do that necessarily either. Okay, so that's 1 in 20 people that we evaluate that are not appropriate, truly. For the other 19 to 20 people, let's talk about their readiness to change rather than their level of appropriateness, because you've made an assumption that they're not appropriate because they're resistant. And that's not a very constructive way to go about thinking, how can I support this person in their long-term goals? Because those other 19, 20 out of 20 people also come to us and say, I want to do big things that I haven't done for a long time. And we say, okay. And then we see them 2 times a week for 6 weeks and discharge them to a home exercise plan that does not progress and give them the opportunity to get there. And so I wanted to mention that as you were talking about that, because change language matters and it stands out a lot when you start to get into this stuff.
Yeah. And this is what makes you different. This is what makes Pinnacle Lifestyle Medicine different. And this is what gets me pumped up every single time we talk. Let's go to the next question. From a business and leadership standpoint, how does a well-designed rehab to fitness bridge change patient outcomes, retention, maybe even adherence, along with retention, and long-term value for an organization?
Yeah. So, I think maybe what I do is say, let me start with the good stuff first, because it'll be easy to start there. What we've learned in implementing this, both at our own sites and then supporting the implementation of others across the United States, if you're a private PT group or a hospital group that's going to transition your orthopedic message from in physical therapy or just physical therapy message period to being one of lifestyle medicine, you immediately become much more desirable as a referral source to referring providers, particularly primary care and medical specialties like cardiology and endocrinology, who have patients that they see that deal with physical pain and disability. And they even know this is probably just because you're not moving a lot. But if I send you to a physical therapist, they're going to, yeah, I hate to say it like this, but they're going to treat you like an auto mechanic and, just address that body part, right? If you start to use the language of lifestyle medicine and medical fitness and show people that you're thinking about the big picture of health, think about how much weight that takes off the shoulders of primary care, that they have a resource that they can refer to that's thinking about health. So just number one, for those physical therapy groups out there that are struggling to get referrals, and I know you exist, this mindset for us has consistently nearly doubled referrals when we've moved from XYZ physical therapy to XYZ lifestyle medicine physical therapy group. From a business standpoint, that's huge, particularly in the private practice world. Beyond that, adding the medical fitness component is a way to diversify your revenue if you do it right. It's a good business opportunity if you do it right. And I've seen a lot of people do it in a way where you lose money and physical therapy subsidizes the fitness component. So going into it with a good plan matters. But it can be a really good additional revenue stream to your business if done right. And it's been really good for us. We went through an early phase of having to what we call figure it out, but we're in a much better place in terms of seeing that product contribute really well, both to the margin and certainly align with our mission of what we're trying to do. Patients crave this level of engagement. There's a lot of people that come to physical therapy that are disappointed that their insurance doesn't cover them coming to see us for more than, sometimes 6 visits or less, which we may knock out in 3 or 4 weeks. And again, for people that really understand where they want to get to, they want to be engaged more often than PT allows them to. Having a fitness component and a focus beyond just that single area of impairment is really desirable to a lot of people. You asked me about patient outcomes too. And I think what's important to say here, I have a ton of anecdotal stories and some good stories from multidisciplinary programs that we've run in the past we're doing a project right now that's really meant to help us coordinate the data collection to show the true meaning of this. And what I mean by that is we're starting to take vitals that would indicate health change at the beginning of physical therapy. And for the people who continue on into our long-term programs, I expect to be able to say within the next year or two that people who start physical therapy and engage in a long-term plan improve their health above and beyond what would be expected otherwise. And
Exactly.
that matters. I think the PT world needs a win like that, that we're making a difference in people's health and lives. And the fitness world needs to be highlighted as a really important component of that, that having a medical fitness service in addition to physical therapy, and having those things work together can really be impactful on people's health and lives. So that's, I guess, where I'll stop.
Yeah. My response to that is I'll give you a sample of one, but it's been just only because it happened a couple of days ago. But there's been one of many conversations I've had on this topic. Just days ago, I had a conversation with a physician here in New York City, Mount Sinai. She's an internist, and we were talking a lot about what you just mentioned. Um, or at least some of what you just mentioned from the sense of like from her standpoint, obviously she's speaking from her perspective and she's obesity medicine. But obviously, people living with overweight and obesity and joint issues and stuff like that. And she said, we need better resources. Like you use the word resource when you were talking. And that's one of the things that popped into my head is I just literally just had a conversation 2 days ago with a physician who's saying that her and her team need better resources um, for long-term exercise and strength training. And that a lot of times, since they don't know the medical fitness side, they don't know exercise physiologists, they don't have that as a resource. So what they'll typically do is refer to physical therapy. Not that that's a bad thing, it's a good thing. But as you and I have talked about a billion times, that's a great place to get people started. And then she would talk about what will typically happen is then they're there for 6 weeks, 8 weeks, 10 weeks, or whatever, and then they're discharged. And the next thing you know, they're coming back to her, and nothing's really changed that much with their health. They might have, they from her perspective, she was hoping that the PT would help getting them move and putting them on an exercise program, but often that's not the case. And so again, it's where that bridge needs to happen from medicine to rehab to fitness. And so, yeah, she used the word resource several times over when we were talking the other day that if they just if physicians were just more aware that these resources exist. And another thing that you talked about was culture change, and culture change has to do with just the wording of how you brand yourself. And instead of branding yourself as a PT facility, brand yourself as lifestyle medicine, brand yourself as medical fitness, and then from there, and again, you've talked about this many times. Now all of a sudden the patient's realizing that, hey, I'm walking in a place that, oh, what is it, lifestyle medicine? And then boom, you're hitting them from the initial eval and on. You're talking to them more about lifestyle medicine and medical fitness and their health and long-term plan. And you started the whole process just with a culture change and just with a change of your brand and the way you name yourself and all that stuff. So those are the things that are going on in my head. And yeah, that's exactly what we need. We need a culture change.
Yeah, I agree. I represent physical therapy at a certain level. And what I think, I get on a podcast like this and talk about all the things that we could be doing better in physical therapy. And I think that may sound like we're not doing good enough. And people take that as as a shot. And what I would want to say to anyone is first and foremost, my identity as a PT. I love being a PT. And I the way that I view that message is we can be better. And when you say the the referral to physical therapy is not good enough, I believe that to be true at a certain level. Here's the thing: refer to physical therapy, please. It's
Yes.
better than not referring to anything. But as PTs down the line, we need to be more consistent at helping solve the longer term problem of supporting people's health. We get so much time with our patients, and there are individual PTs out there doing really great work on this, but we got to be more consistent about it. And I think being a part of the long term solution in having these things, it's not on the individual therapist, it's on the business that they work within to take this on.
Yes.
Your point is a culture change. I'd never want a single physical therapist to leave thinking, I got to do more work without support on this. I think this is a professional change that needs to happen. And so
Yeah.
that's the
It's a
last thing.
professional change that needs to happen, and it's a professional change that you're, involved with at a really high level. So,
Yeah. Yeah.
I absolutely love it. All right, one more question for you, Thomas. If you were advising a clinic or health system that wants to build this bridge but feels overwhelmed, what are the first one or two steps that they should take to get it right?
Yeah, I don't want to overcomplicate this necessarily. What I'll tell you is I've seen a lot of groups do this with one mindset of two, and that you need to use both mindsets. And that is, there are groups that have gone forth with trying to adopt a set of processes and medical fitness service line that are purely mission oriented. We want to do this because it's the right thing and because it reinforces who we believe we are. And there's another group that goes forth and says, we want to do this because we need to diversify revenue. The reimbursement in physical therapy and other therapy services is not paying us enough. We need to find something else to make money. And I got to tell you, if you do one extreme over the other, you're setting yourself up for failure, because if you go too mission forward without thinking about the business implications and setting that up intelligently, you're going to get stuck doing something that feels really good but costs you a lot of money and ends up being a drain. And nobody wants that feeling. On the margin side, you could devise a really successful financial program that does nothing to support the health and well-being of your patients. Um, and I think there's a lot of gimmicky things that you can adopt out there that are like that. That's fine. I don't mean to judge any of that stuff. People like doing, different things. I'm not going to name anything specific because I don't want to offend anyone. But I think you have to think both in terms of how is this going to be financially successful and how does this align with our clinic's identity and the patient population we serve. And knowing those things as the business owner or the clinic director, whoever's going to be implementing this, are really important. I guess the second thing that I'd just say briefly is, if exercise program design and implementation is not your expertise, let an expert do that work. Like, if you don't know what you're doing, but you have seen some cool things on Instagram or TikTok and have been to a conference and somebody talked you into something that is flashy, I just take a step back and get some advice before taking a step forward. Like, there's way too many ways to do this wrong, and too many flashy solutions that promise results that you could get stuck with that cost you too much money. And again, don't support the original reason that you would have gotten into doing something like this. I just really encourage anyone who's considering, find someone who knows what they're doing and talk to them about this before taking your step forward. And I think you might be able to avoid a lot of headache and pain over time. So
Yeah. No, this is great. And what I was thinking about as you were mentioning all this stuff is, again, my research and how I feel like with my research I'm tackling, at least with the initial pilot, I'm tackling like the clinician to patient conversation and trying to optimize that and help to provide the tools for clinicians to provide solutions to barriers, understand readiness to change and how to change the type and tone of the conversation, etc. But the point I'm getting to is that it was because of a meeting with you and Sheila and Andrew, the other members of the dissertation committee, where you mentioned the business aspect, and I hadn't been thinking about that. And so it made me realize, yeah, you know what, Jeff, what you're doing is needed, but it's a little bit on the idealistic side because you're not thinking about how to scale this from a business standpoint. And so that's what was going on through my head, is that you really do need to think about this from both sides of the equation. How do you want to better the culture and do this for all the right reasons, but also, make this realistic from a business standpoint, et cetera. So you actually, your mindset has helped me with my research and, thinking about the long term as well. So it just applies across the board, I think. And we just
yeah,
happen to be focusing in on the how it applies to the rehab to fitness part of the whole continuum.
Yeah, and Jeff, what you and I end up talking a lot about is that we ask the ultimate delivers of these medical exercise programs to get a lot more training and expertise, um, and often don't think about the expense of that additional training and expertise and what that should give them as a payoff. And if we don't design programs where these people with additional training and expertise can make money that makes it reasonable to make this a career and not,
Yes.
just a job out of college, then it's not going to be a sustainable system. Like,
Yep.
solution is not a sustainable thing if we can't make better lives for our fitness professionals. And that's true for me with our physical therapists, by the way, too. That a lot of what we're trying to do is just make sustainable careers for us in medicine, but also solve a really big problem that exists through knowing our role really well in medicine. And I think you've done a really good job of taking that to heart and appreciating that. You take that to heart as a business owner who employs fitness professionals, right? Like, you don't want to employ people in a position that feels like they're underappreciated or represented, that asks them to get way more training, and then does nothing to pay them more than the base personal training job they could get with a weekend degree. So yeah.
Yeah, you're exactly right, and that's absolutely on the front of my mind as I head quickly towards the start of my research intervention and hire these coaches, et cetera. So, hey, this has been great, and as we always say, we know that we could talk about this forever. So this is part one. We're getting ready to, for you and me, it's going to be, probably next week when we start part two. Maybe we'll have you in part two, and maybe we won't. We're going to figure that out between now and then. But as far as our guest goes, we're probably just seconds away from part two. But in any case, Thomas, thank you so much for being a guest on our podcast and allowing me to pick your brain a little bit with today's topic. And we'll see you the next time.
Yeah, thanks, Jeff. It's been fun.
Calling all fitness professionals. This spring, the Medical Fitness Association is hosting 3 powerful medical fitness summits in Greensboro, North Carolina, Jennersville, Pennsylvania, and Columbus, Ohio. Join us for 2 high-impact days filled with inspiring keynotes, practical educational sessions, interactive roundtables, a fun social event, and nonstop networking with leaders across the medical fitness industry. Don't miss your chance to learn, connect, and elevate your practice at the Medical Fitness Summits. Visit the Medical Fitness Association website at medicalfitness.org for details and to register today. That's medicalfitness.org.
Hi, everybody. David Flench here, and we are moving on to part 2 of this episode, loosely titled Building the Rehab and Fitness Bridge. So in part 1, Thomas and Jeff had a great conversation helping us understand where the rehab to fitness handoff breaks down and why so many patients leave physical therapy with a home exercise program instead of a long-term plan. So today, Jeff and I are going to zoom out and zoom forward. If part 1 was about diagnosing the gap, part 2 is about designing the bridge. What does it actually take operationally, culturally, and financially to move somebody from rehab into sustainable long-term exercise? And what role do exercise professionals and leaders play in making that happen? So, Jeff, let's start with the exercise professional lens. From your experience inside medical fitness centers and working with referral pipelines, what is the biggest mistake exercise professionals make when trying to receive patients from rehab?
Yeah, this is a great question, and I am going to tackle this from my own experience standpoint. And I'm going to start with the fact that we unfortunately just operate in silos, and therefore the associated lack of communication and the associated lack of trust. So going back to my Mount Sinai days, way back in 2006, it's so hard to believe it was 20 years ago, but way back in 2006, um, you know, it was my second time working in this type of setting, but it was my first time working in a leadership position because I was the founding fitness coordinator, and now I'm working alongside 30 plus clinicians across a pretty wide spectrum, family, internal medicine, orthopedics, et cetera, et cetera. And I was scared. And so for me, I was kind of scared to communicate. I didn't know how to speak their language. I didn't know what to say to them, and I didn't want to look stupid and all that stuff. So for me, I created my own barrier because I just didn't know how to speak their language. But it didn't take me long to realize that this is a problem. The referrals weren't coming in at the rate that they should have been, and I started to just realize that this is part of the problem, and I need to communicate better. So fortunately, we were having regular in services and journal clubs that I was attending. So now I was at least getting into that type of mode and realizing that, hey, I need to present as well. It isn't just attending here. So first of all, I need to show them that I'm committed. I need to show them I'm committed, and I need to not just attend but present as well. So I was scared to do it, but I started leading in services. I started leading journal clubs, and really using that as a way for them to see that, hey, I'm skilled too, and I operate on this continuum as well, and you can trust me, etc. So it was just a way to communicate and a way to show my skill set as well. And I've learned across my career at working at different hospital settings, private practice settings, if you're out of sight, many times you're out of mind. And so you got to stay in sight. So that's part of the whole, we can't operate in silos. You have to figure out a way to break the silos so you're not out of sight, out of mind. And then as time moved forward, I started realizing that, big problem with this disconnect, and going back to the original question, what can exercise professionals do? We need to learn the language. We don't speak each other's language. It didn't take me long to realize that, hey, I definitely don't speak their language, with understanding. I'm actually getting ready to talk about the things that I didn't understand, but I also realized that, what, they're not really speaking my language either, as far as like exercise science and exercise prescription and strength and conditioning and things like that. And that's a reason why we need to have in services and journal clubs and doing things like train them. So I started realizing that early as well. I can't just sit there and receive referrals. I need to train them and offer them complimentary consults and complimentary sessions, and use that as a way to not only again show them my own skill set, but to learn from them. And that's when I started to realize, as I'm learning from them, that the language they speak that I need to learn is things like, when it comes to this, various conditions, etiology, what's the cause, pathophysiology, stage progression and the associated symptoms, the common medications, if that applies to the situation, and the associated symptoms with that, the precautions and special considerations, and the exercise contraindications. So these are things that, nowadays in a lot of exercise science programs, they teach this stuff. But when I was in school, we didn't teach it. So I didn't know how to speak that language. And it was so important for me to train them, speak with them, attend these journal clubs, break down these silos, and realize, so this is the language they want me to speak. This is what makes them feel comfortable. And then, even from the musculoskeletal side, and the language of like pain management and therapeutic exercise, and knowing how to regress and knowing how to progress properly and knowing how to meet the person where they're at and things like that. So that was one of the answers to the question, that exercise professionals can do better. We just need to be able to learn those things. And now we live in this age of AI, where back in the day, where do I find this information? I didn't know where to find it. And now there's all kinds of places you can find. You can find it, ACSM's guidelines for exercise testing and prescription. You can Google it, but we can also go to Chat GPT and Google Gemini and Perplexity and stuff like that. And it's so much faster, and have them, give us access to links to YouTube, besides answering the question itself, etc. So that's one of my answers. And then briefly, I just also want to just add, when it comes to gaining the trust, and receiving more referrals through that trust, you can't train the referrals like they're a regular, a typical client, like you'd like the apparently healthy that you'd find in a health club. And in my experience, uh, I hate to say it, but it's just how I feel. The health club industry as a whole, I didn't paint a broad brush, and it's not completely fair, but as a whole, it repels a lot of clinicians because it's all about entertaining and getting them sweating, and things like that. And that's not really what clinicians want to see when they're referring patients with, multiple sclerosis or lupus or significant knee pain or low back pain or whatever. You can't just go into it training like a typical client. So part of that goes back to what I was saying previously, where you need to know stage progression, associated symptoms, medications, and how to modify things, the precautions and contraindications. When it comes to, actually, let me backtrack. I look at programming and also just working with client, kind of two categories or two buckets: hard skills and soft skills. So I think the clinician kind of assumes that you have the hard skills, the sets and reps and RPE and the exercise you're going to do. I think they kind of assume that the trainer, the coach, understands those things, although I would say that maybe they do and maybe they don't. But what they're interested in my experience, is the soft skills. Your ability to meet them where they're at, to show empathy, to learn from them, not just act like a dictator and teach them, hey, this is how we do things here, but to learn from them as well, because they're the ones living with their condition. You can absolutely learn from them how there's the textbook knowledge, but then there's the, hey, how's this affecting your activities of daily living? How's this affecting you when you exercise? Doing things like allowing autonomy. What do you want me to emphasize? What do you want me to avoid? What are you apprehensive about? So you make sure that you don't include those things. You don't just make assumptions and include those things in the program because you didn't ask them. And then all of a sudden you learn that or you can see that they're very apprehensive about it. So, that's what I mean when I talk about soft skills. I'll just throw another one or two in there. Auto regulation, which, for those who don't know what that means, it's just jargon that means, adjusting the session based on how the person feels. And there's two categories of that. One is called readiness to train. So it's just a screening. And you should, the coach or the exercise specialist should screen the client every single time prior to every session. How do you feel? How did your body respond to the last session? Did you eat? Are you hydrated? Did you take your medications? So there's a screening process. And then there's within session auto regulation. If they're not feeling as up to it that day, you need to not just go off some program that you wrote out, but you need to know how to adjust on the fly, creative thinking, critical thinking, stuff like that. So, as you can tell, I could probably go on, but I think I'm going to stop with that. We need to communicate and we need to gain their trust. Those are the two best things that we can do, the lowest hanging fruit that we can tackle first in order to start receiving more patient referrals.
You made so many good points. I just want to kind of, recap some of that. Like the idea, I'll just say it this way, where when we're trying to receive patients from rehab, it can't be just a build it and they will come approach.
Yeah,
It's got to
well said.
you got to have the relationships. And while I agree, there's more tools now than there used to be, in terms of learning the language and learning where each other are coming from. So you mentioned AI. One thing I love AI. I use ChatGPT and other AI platforms probably every day now. But I will say there's the danger of reading something off of AI and all of a sudden thinking you're the expert,
Yes.
and you're really not. It's no more than anything else. So that's one, I think, challenge. But going back to the relationships you mentioned in services, and there's so many ways to build these relationships. And I can think back to early in my career, at the Connell Heart Health Center in Ohio. We had a really well integrated medical fitness center, and it had a robust physical therapy department, sports med doc on staff. And we did regular in services where it wasn't just one directional either. It was both sides, educating the other. Now, I'll say from my perspective, I learned so much from the physical therapists and the sports med docs. I don't know how much they learned from us. Hopefully, a little bit when we did ours. But that was a huge part of my initial training in the industry, and to have that, and personally helped me, but I think overall for our facility, that regular time together helps so much with the relationship building. And so that, in itself, just developed the trust that you can't substitute otherwise. But, of course, we had to have the proper training, education, etc., to gain their trust. But then it was, having that regular communication. You hit on that really well, and I do like the idea that you have to, you can't treat every referral the same. You certainly can't treat them just like anybody in the general public, especially if they have some special considerations to take from it. So I think you hit on so many good things, and you're right. We could go into this quite a bit, but I think you hit on so many good tips for what that referral should look like, and what are the important components. So thank you for that.
Absolutely. So let me now tap into your expertise and ask you a question. Flip it over to you. From a leadership and industry perspective, what's preventing this rehab to fitness bridge from becoming the standard of care?
Yeah, I mean, I think you hit on some of these ideas, but so I'll certainly say the professional silos are one big reason that this does not become the standard, because a lot of times we've found that until you develop these relationships, the therapy department is a little bit concerned with handing their patient off, as they probably should be. If they don't know you, they don't know your background. I'm not sure if I was in their shoes that I would be referring. So if it's just that you're a fitness center here, that's probably not enough. So having some of these relationships built so that you can break down these professional silos, and make somebody comfortable with sending their patient that they just spent at least a few weeks with, if not a few months with, rehabbing from maybe an injury, or whatever they were there for rehab. They don't want the regression to happen, and certainly regression can happen from sending them home on a home-based exercise plan and them not doing that. But it can also happen if they're not, if the program isn't done correctly after the referrals. If it's at a medical fitness center or any other type of facility that a handoff is happening. But I'd say, there are other things. Reimbursement is a problem right now. So typically rehab is reimbursed by most insurances, at least for a defined number of sessions. And then the fitness center usually is not. Most of the programs and services have no reimbursement structure. So until something like that exists, that's one hurdle that I do think there are many ways to get past that. So, typically the out-of-pocket payment isn't so high, and the value should be there, especially to continue the good work and keep somebody's health progressing in the right way. But I would say that and we're seeing some things nationally and otherwise, pointing to this changing. So I think there's reason for optimism and encouragement that things are being put in place. A lot of good work being done in the industry, but we're not there yet. So I think that is certainly preventing this as a standard of care. Then I would say, there aren't any. I shouldn't say aren't any. The standards aren't well implemented and applied among all facilities. So MFA, we have the facility certification that has 131 standards and guidelines that exist to help this, rehab to fitness bridge. But not everybody is using this, and we still have a long ways to go until people have some set of standards that they're using in their programs and facilities. So I think that's an issue that continues. We're doing some work in that, others are doing some work in that, but I think the industry has a little ways to go still. In past podcasts, we've talked about outcomes. we had a whole podcast devoted to what that meant. I think we had some great discussion on that, but I think the executive level outcomes metrics really a lot of times facilities aren't putting that together, so there's not a support of what's going on because there's no tracking of this, and so there's less visibility into why this is important and how it's helping. I'd say even outside of the executive level metrics, there's all the way down to the individual level metrics that a lot of times aren't being tracked either. So I think that loop back to rehab of being able to communicate some of the outcomes after a person's either gone through a fitness program or just however you're doing that, that needs to be there. And when it's not, that decreases the level of trust. And so I think, finally, I'd say that, a lot of times it's physical therapy is seen as the end point. And really, there's exercise and lifestyle changes really need to be maintained over a lifetime. And so it shouldn't be seen as, oh, I went to rehab, I improved my back pain, whatever it may be, and now I'm good. I don't need to, do anything anymore. Well, obviously there was, whether it was an acute injury or whether it was a chronic condition over time that developed, it wasn't something that you were ready for. And so it was something that you can't go back to doing nothing, or you can't go back to your old ways. It needs to continue. I think I'm preaching to the choir here on a lot of that, but I think a lot of people do see physical therapy as, I went through that, I'm done. Now I don't really need to worry about anything. And that's just not the case. So to me, it's more of a systems design problem and less of a, physical therapist and exercise professionals not knowing what they're doing. It's really the system needs to be designed better and, really making sure that that connection is there on all those different levels.
Yeah. So listening to you, needless to say, number one, I agree with every syllabus that came, I mean, out of your mouth. And but number two, right before we hit record, I told you that I got IRB approval, and so I literally am starting my research right now, and so I can't help but think about what you said, and really just this whole issue from that perspective. And I'll just briefly say that the top down, the systems level stuff and all the changes that need to be made at the, for the executive level, the systems level, stuff like that. Absolutely. It's a broken system and we need to tackle it. And fortunately, organizations like the Physical Activity Alliance and others have been and are tackling this from the top down, and the Medical Fitness Association, like you said, with your guidelines and standards, and and people need to know about these. You need to have that standardization. So without a doubt, but while we're working on the top down, we also can tackle things from the bottom up, and that's really what I'm trying to do with my research, which you also hit on, with your response, and the fact that we operate in these professional silos. And so, again, that, to be honest with you, to me, that goes back to the culture change. It's one of the first things you need to think about. If I want my facility to be successful at all points, at the individual level, with the patient, at the revenue level, with my particular facility, what's happening right now isn't the right, it isn't doing the job. So we need to start by changing the mindset, changing the culture, understanding that silos are just ruining everything. And to me, that's one of the lowest hanging fruits. Let's break down, how do we break down these silos at my facility? And at the very least, it should start with things like in services and and group meetings, so that we're all talking to each other. Like, for example, my first job out of college, when I was at Duke Medical Center, we had medicine, fitness, nutrition, and behavior components, and we had weekly staff meetings where we all got in the same room and we just talked about cohorts coming in or whatever the case may be. And I was like, this is great. I kind of assumed this is how the medical world worked, and then realized that no, actually I just was in a unique position there. But in any case, and then like you also said, and the last thing I'll address is PT being seen as the end point instead of being the first step to longer term. And Thomas really hit on that in part one of this episode. And it goes right back to culture change, and the clinician themselves has to see this more as I'm just fixing someone's broken part, but rather there's a person in front of me. And I'm a healthcare provider, and I absolutely can help instill in their mind that this is longer term and that we need to pass the baton to the fitness professional. So there's my response to that. Good stuff.
Well said. Let's go to my next question for you. So, if a clinic wants to operationalize all of this tomorrow, um, even in a small way, what is the simplest viable version of a rehab to fitness bridge?
And I wish I could answer this question and then directly, like absolutely directly, and say, yep, great question. Here's exactly what you do. But instead, I'm going to be redundant, which might be a little annoying, but I have no other way to respond to this and say that again, it really starts with the culture and the mindset change. So I apologize for sticking with that, but I just really feel like you and I have talked about this so often. Thomas and I, Andrew Mock, who's been a return guest and is on the board for the MFA and Superstar, that's what he'll talk about is you have to start by changing the culture, rather than just thinking that, hey, tomorrow I'm gonna operationalize this. Now, with that said, my experience and expertise is more from the ground up. And not that you don't have that expertise too, but you definitely have way more expertise than me in the top down. So maybe you can address this after I finish my thoughts here. But I just feel like, going back to what Thomas said in part one, that you need to, his suggestion was rebranding your facility as lifestyle medicine. And there's part of the culture change. We're not a rehab facility. We are a lifestyle medicine facility. And then again, you want clinicians on your staff that are invested not just in fixing a broken part, but in their patient's health. So it kind of starts. I'd almost backtrack and say, it's not like facilities can all of a sudden just fire everyone and rehire. Not that they would need to do that, but just to get my point across, it almost starts with the hiring process and just making sure that you're hiring clinicians who are fit, the cultural fit into your culture, and that they are going to buy in to that and not feel like it's just about fixing broken parts and things like that. So, you need the clinician that's invested in the patient's overall health. Similar to what Thomas has talked about on this podcast many times, really starting that conversation from the first visit or very early on in the rehab process, that, hey, we can only do so much in these 8, 10, 12 visits. And then we're going to be, I want to talk to you about your long-term health. And, it was great in part one of this episode where he talked about this 2-question survey that they've started doing over the last 6 weeks, asking the questions, if I can remember correctly, how their health, if they'd be interested in learning more about how their health is affecting their condition and how nutrition and long-term recovery can optimize health. So, surveying, starting with the survey, and what do my patients want? And how can we change the culture here? I thought that was amazing that they started with just this real simple survey. Let's see what our patients want. Oh, they actually do want to learn more about lifestyle and long-term health and things like that. So now let's create what we need, within our model, what we need to address that. So, and the last thing I'll say is, again, going off all my conversations with Thomas over the years, you need that face-to-face, like as early as possible, where the clinician introduces the patient somehow to the fitness professional, so that there's that face-to-face contact, and that it really sets up the warm handoff. There was a year that I lived out in Los Angeles way back in 2010, 2011, and that's exactly how the model was set up there. So the clinician, and actually even at Mount Sinai when I worked there, my best referral sources would stop and say, hey, hey, Jeff, come over here. I want to introduce you to so and so, and get that handshake. And now that really starts that handoff. It starts that trust. And if I can be there as well, whether just observing or somehow being involved. Like, for example, many of the physical therapists would say, "Hey, Jeff, if I wasn't training someone at the time, come in the treatment room here. I want to show you what I'm doing, or can you help with this? Can you help with this therapeutic exercise here, or something like that?" And all those little things really, really matter. So I think it's way more about just changing the culture and doing things like that. And then once you do things like that, then you can determine, okay, so what programs do I want to offer here? Do I want to have like a low back, herniated disc program, or a lumbar spine program, or a knee program, and then use your culture change to then enhance the program, and then from there operationalize what you're trying to do.
I love how I mean, basically you're saying there is quite a bit of system design that needs to be taken into account before anything else can be done. And I fully agree with that because it goes back to everything that we've talked about so far here. The communication, the education. You hit on so many good things, and yeah, I mean, so that's from like the physical therapy clinic side. And even rebranding themselves is a strategy, a system design type of
Absolutely.
strategy. And I'd say you started to hit on some things I think even from the fitness side that can be done. And I think I mean, you are probably one of the top people I'd think of when I think of progression planning. And so making sure that whatever they were doing in physical therapy, there's a proper defined plan to progress them. And it may be a lot lower level than some fitness facilities are used to doing, but they have to understand what level this patient is starting at, and what is a proper progression plan to increase over time. A variety of factors that they can do. So I think and having that type of knowledge, and not just having a cookie cutter type of program that somebody goes into is, and you can have, I think fitness centers can have these types of programs. They can have a low back program. They can have a program for a specific disease. But within that, I think there's so much need for the exercise professionals to be equipped to handle them, each person individually, and address those concerns individually. And just because one person's MS, looks one way, doesn't mean the next person's does. So it can't be, one type of program only. There has to be just, so much more than that. So I think, the and geez, there are some facilities that don't have any of this. They don't have a program. They don't have enough. It's just, we got a referral. Now you're a member, and you're going to go through just what our general membership goes through. And I that's certainly probably the worst case scenario, is that you're just thrown in with everybody else and good luck. So I think you hit on a lot of the small things that can happen, but thanks for all your insight there.
Yeah. And, first of all, I appreciate that. And I wish we did have time for, more questions, because as we always say in pretty much every episode, we could just keep going and going and going since we're so passionate about this. But as we wrap up, you know, the way I look at just not only part one, but what we've been talking about here is you really have to look at the whole picture. You got to look at the whole ecosystem, and you have to understand that there needs to be systems change. And now we've talked a lot about what that means, and we've detailed it. And systems basically from the top down and the bottom up, and that it really, so much of it is just communication, communication, communication. How at each facility, how can we start optimizing communication? And then how can we use that to improve the programming, the handoff, and also just trust across the board, things like that. So those are my final thoughts. I don't know if you have any yourself.
Yeah, I think it's just important to note that we're not talking about replacing anything. Rehab, it's definitely a major part of the continuum, and it really is that we need to complete this continuum and
Yes.
make it more integrated. And, you go from medicine stabilizing, rehab to restoring, and,
Yes.
medical fitness building the resilience over time. And if we want fewer recurrences and preventable injuries, if we want more durable outcomes, we have to stop treating discharge as it's the finish line, and the real finish line is building the long-term capacity. And a lot of the programs that we had, one of the stated goals was that we would build confidence in a person to eventually do more of these things on their own. So yes, initially holding hands and guiding, that is extremely appropriate, but it's also building skills for people to incorporate this into their lifestyle, into their overall fitness and lifestyle program for themselves. And so I think making sure that this continuum is happens well. If it this continuum should have some structure to it, and should have some system design. So as you said, it's a lot of the top down, but it also needs that bottom up approach of the exercise professionals and the physical therapists and rehab professionals working together on a regular basis and having that communication. So I think these are some really good thoughts that I hope the audience has enjoyed. And I think that's going to wrap up this episode.
Yeah, I think it's a perfect way to wrap it up. I loved the discussion. Love being able to chat with you about this, David. And I guess we'll see everyone on the next episode.
All right. Thanks, everybody. And look forward to future episodes on the Medical Fitness Podcast.
This episode of the Medical Fitness Podcast is brought to you by the Medicine, Rehab, and Fitness Institute. The MRFI has been co-founded by medical, rehab, and fitness practitioners who see the medical necessity in getting people to be more active and fit. There is a sleeping giant of opportunity to building a more active population, an opportunity which lies in a more effective medical referral pathway to exercise programs and professionals equipped to serve that pathway. To learn more about our services and how we're working to make this a reality, visit mrfinstitute.org. That's mrfinstitute.org.